Welcome to Victim to Victory, the Personal Injury Playbook, the podcast to navigating the complex legal system after an injury. We bring you the expert insights and guidance you need to navigate the legal system with confidence, help you make informed decisions, and get the compensation you deserve. Don't let insurance companies take advantage of you. This podcast is designed to empower you with the knowledge you need to protect yourself and your loved ones. So sit back, relax, and let's start exploring the world of personal injury law together.
Welcome to today's episode of the Personal Injury Playbook. Today we have Dr. Didier Demesmin, a board-certified interventional pain medicine physician. He is the founder of the University Pain and Spine Center. Dr. Demesmin treats a range of pain syndromes and specializes in minimally invasive procedures. He's also involved in clinical research and presented his work internationally. Welcome to the show, Dr. Demesmin.
Thank you so much, Mr. LeBrocq. Thank you for the opportunity.
Absolutely. For those of you watching today, Dr. Demesmin is also the gentleman on a lot of the periodicals you'll see in the airport, or if you're on a plane, one of the top doctors in the world who practices in the field of interventional pain. So it's our privilege and honor to have him here today.
Much appreciated. Thank you so much.
And as good a doctor he is, he's probably a better person. So we're going to dive right into this now, Doc. What got you to specialize in interventional pain medicine, and how did you get interested in that field?
So, I kind of got interested in the field, actually. So I started my career doing obstetrics and gynecology, but a long time, maybe when I was about 16 years of age, unfortunately, my mom passed away from cancer. So I grew up in Haiti, and at the time, there was no pain management available. So I saw my mom just going through her cancer battle, but not only the battle of the cancer, but the fact that she had a lot of pain. And that was actually more devastating for us, my sister and I, more than the diagnosis itself. So coming here, and I'm like, you know what, I want to do a field that's probably going to help take away patients' suffering. So that's why it led me to the field of pain management to begin with.
All right. And you actually do a lot of work with cancer patients in your treatment.
Absolutely. In addition to treating sports injuries, like a personal injury patients, I do a lot of cancer pain as well. So it's a way of giving back. And I think these patients are in need of a lot of my services, and I take real good pride in doing so.
Yeah, and I'm sorry to hear about your mom. I've known you for several years and I never knew that. My father actually passed away from mesothelioma, so I can't even imagine the amount of pain that woman went through, because my dad suffered terribly and he had pain management physicians helping him. So I can't even imagine you having to go through that. But that would motivate you to try to help other people and put you in that field.
Absolutely.
We appreciate your dedication to the community and helping others the way you are.
Thank you so much.
And can you describe some of the most common syndromes that you treat, and what is your approach to treating them?
So a lot of the patients that I treat typically present with lower back and neck injuries. So commonly they'll present with disc herniation, disc bulges, nerve compression, and they'll present also with what we call facet syndrome. And so typically what I do, so I use what we call a conservative step approach first. So a lot of these patients require physical therapy first, chiropractic care, but when this patient fail, then they come to me. So the treatment algorithm that I offer is, how do we manage the pain and also offer a way of solving the problem itself? So the way that, for example, if it's a patient has a disc herniation, basically, so to help manage the pain, doing things like nerve block epidurals will help reduce inflammation around the nerve. However, if you want to treat the problem, meaning that offer a corrective solution, then I do things like microdiscectomies, annuloplasty, and some lumbar fusions as well.
All right. So when we're talking about back pathology, it could be pain coming from the disc, which is basically that shock absorber. It looks like a jelly donut in between our vertebrae. But it also could be emanating from the facet joints, which are the interlocking bones which surround or part of the spine, but surround the disc and the vertebral complex. Is that accurate?
That's accurate, correct.
How do you treat a disc as opposed to pain that's coming from the facets surrounding the disc?
Okay, so the disc, just like you explained, like so the disc is actually the cushion that's in between the two bones. So when a patient gets into trauma, what occurs is the disc itself is going to move, is going to protrude away and put pressure on the nerve. So the nerve compression that results because of the disc herniation will cause inflammation around the nerve. So the simplest thing to do is like using medication like cortisone to put around the nerve just to reduce inflammation. However, the conversation I have a lot of my patient is doing the epidural, the cortisone shot doesn't fix the problem. It's a palliative procedure, meaning that you inject medication just to reduce inflammation, but the disc herniation is still there. If the injection by itself failed to give the patient long-term relief, then we move on to doing things like discectomy and possible fusion. The second part of the question is, how do you treat the facet, which is the joints around, the interlocking joints around? The one thing that I always tell patients is, a lot of time when you're looking at an MRI, you'll be able to see the disc herniation, you'll be able to see that visibly, but sometimes, actually most of the times, you may not see a facet problem, a joint problem. It's more of a clinical diagnosis. A lot of time a patient gets into a car accident or any like fall down injuries or anything along those lines, they present with a facet related pain, but if the clinician doesn't know how to evaluate it, they may miss it because you're not going to see it on films. So the way we treat that is by making the diagnosis. And the way you do that, in addition to the physical examination, sometimes you see spasm around the facet joints, but we do what we call a facet nerve block. So by doing a facet nerve block, if the patient responds with a positive response to it, then you can actually not only confirm your diagnosis, but that would be a form of treatment as well for the patient with facet syndrome.
Now, you mentioned about doing a cortisone injection via an epidural. Now, that's a little bit more complicated than just your typical injection, isn't it?
Absolutely, because the way you do the epidurals, you have to use what we call a fluoroscopy machine, which is actually like a live X-ray machine, so you can actually see exactly where you're going to. So the epidural itself, even though it's commonly performed, but it's actually require a lot of skills to be able to do it because you're injecting medication with a long needle millimeters away from the spinal nerve and also from the spinal cord. So when you're doing it, the doctor has to be very well trained, be as accurate as possible, and do it under live visualization with the fluoroscopy to make sure that you deliver the medication directly into the area where it's supposed to be working.
And then you also do a different injection called the nerve block, you said, for the facet joints. But now if this epidural doesn't work, you said you do another procedure called the minimally invasive discectomy. Now, you and I know what a discectomy is, but could you explain that to a layperson?
Sure. So let's step back a little bit. So the one analogy that I like to use for a disc herniation is what we call the jelly donut analogy. So meaning that if you're looking at a jelly donut, you're going to see the donut and the jelly is inside of it. But the jelly, you don't get to see the jelly unless a trauma occurs to the jelly donut. So meaning that if you were to crush the jelly donut, the jelly comes out. And that's what a herniated disc is, the jelly coming out of the disc. So when the jelly comes out, that jelly part, the nucleus pulposus, which is a jelly, will compress the nerve and cause what we call nerve root compression. When that occurs, you can inject medication around the nerve to help reduce the inflammation. But if that doesn't work, then you can actually have to clean up that jelly. So meaning that the discectomy involves using tools to go directly to remove the part of the jelly that's compressing the nerve. And sometimes, like you described, it can be as minimally invasive, meaning that it's not a small procedure, but we call it like a less traumatic procedure where you can actually make an incision, go directly to the source to clean out the jelly that's compressing the nerve root.
And how does that minimally invasive discectomy that you perform differ from the traditional approaches to back surgery?
So very, very good question. So essentially the results are essentially the same. So the minimally invasive procedure that we do, it's actually, we call it minimally invasive, but it's actually, we call it less invasive procedure, meaning that a traditional surgeon, when they do their microdiscectomy, they sometimes have to remove part of the bone to get to where the pathology is. But if the patient's pathology is not encased behind the bone, so sometimes you may not need to remove the bone, so you can actually access the disc itself by making a small incision and using small tubes to go directly into the area. A lot of time, the analogy that I use is a lot of time, like, for example, like if you have like a heart problem in the past, you needed open heart surgery, but there's a lot of interventional cardiologists now that do, you can use stents, you can use like a lot of different things to still treat the same problem, but offer the patient different option. So both options are viable, but again, it's just like a patient preference. Sometimes the patient's like, can I do something that less invasive so that they can they do not take a lot of time out of work. So that's when we offer those options to them.
So the minimally invasive procedure, as opposed to the more traditional surgery, it cuts down on the recovery time?
Absolutely cuts down on the recovering time, and there's also less muscle trauma, and sometimes we may not need to remove a lot of bone. So it's a nice option for patients. Sometimes the injury or the disc herniation can be so large where you cannot do it minimally invasive. You have to use a whole traditional, a lot of things to do. But if you still have a disc herniation that can be amenable to something less invasive, we pride ourselves in our practice to have the ability to offer that as an alternative to the patients.
So how do you work with other healthcare providers, such as your primary care physicians, your physical therapists, chiropractors, in order to ensure that the patient has complete and comprehensive care? And that may even go with a neurosurgeon or an orthopedic surgeon.
Yeah, so that's a very good question. So the way that I see medicine is like it's actually it's a whole team effort. So meaning that if a patient presents with a trauma to the lumbar spine, but if the patient has any healthcare conditions, for example, they have poorly controlled diabetes, poorly controlled high blood pressure, obviously before doing anything like an epidural or nerve block or any kind of surgery, I want to make sure that the patient is stable enough to undergo those procedures. So a lot of time I would ask like for a primary care consult to make sure that the patient is optimized before doing kind of procedures. A lot of time, like I explained earlier, when a patient presents with an injury, so before they get to see me, a lot of time we recommend that they see chiropractors, physical therapists to make sure that they go through the algorithm of doing conservative care prior to doing any kind of interventions. But even during my interventions and even after surgery, this patient may still need chiropractic treatment and physical therapy to try to rehab the musculature, because when a disc injury occurs, two things happen. The nerve gets compressed, the patient has pain, but also there's weakness. The muscles of the back become atrophied, meaning that become a little bit weaker. So in addition to treating the problem, we need the care of our healthcare associates, like a physical therapist, to make sure that you rehab the patient so the patient can get back on their feet to be able to go enjoy what they like doing, taking care of their families, going back to work, enjoying sports, traveling, or whatever it may be.
Now, we've talked a lot about spines, doctor, and herniated discs. Do you treat any other areas of the body for pain?
Yes, I also treat like a patient with shoulder injuries, patient with hip injuries, patient with what we call sacroiliac joint injuries as well, which is actually the two bones, part of the back, what patients sometimes often refer to as their hip in the back of the pelvis. Sometimes it gets injured also during the accident. So we treat a lot of these, all the gamut, shoulders, knees, ankles, and everything else.
So what are some of the most challenging cases you've encountered in your practice? What was your approach to pain management in those situations?
So some of the most challenging cases sometimes occurs, for example, like if a patient had, let's say like they had a previous, like a lumbar fusion, which is actually getting a big back surgeries before the accident where they have screws, bolts, and everything in their back. So now they get another injury. So that means that the segment of the lumbar spine was already weak to begin with. So now the patient becomes a lot weaker. So that makes it challenging because a lot of times the patient, to do the epidurals, when a patient already has back surgery, There's a lot of scar tissue that can be around the nerve. So trying to inject medication around the scar tissue may be somewhat complicated, but we still get around doing it. But other challenging cases that we see as well with patients that have like a lot of weakness. For example, if a patient has a large herniation enough where the patient can actually get almost to the point of paralysis. So we have to recognize that immediately and use our neurosurgical colleagues or spine surgical colleagues to be able to get the patient in immediately to make sure sometimes the patient may need emergency surgery as well. So there's a lot of the way that we see medicine is the way I view medicine, it's an art, meaning that every patient is actually doesn't fit into one box. So always take into account the patient's medical problems, the previous back surgery the patient may have had. Is there any other what we call comorbid conditions, any other factors that may be affecting the patient to make sure that we give the patient like a plan that's directed for them.
So you mentioned people working with people that have had fusions that have had as being challenging. How about in a situation where a person has a significant back surgery, whether it's a laminectomy, a fusion, where they have failed back syndrome? How do you treat a patient like that that's gone through surgery, sometimes multiple surgeries, and they're still in horrific pain?
Yeah, so when a patient have what we call failed back syndrome, meaning that the patient had the previous lumbar surgeries, the fusion, etc. So there's something that we do called neuroaugmentation, otherwise known as spinal cord stimulation. So what that is the simplest way of thinking about it is when a patient has back surgery and continues to have pain, so it means that the nerve themselves underlying the fusion is not working properly. So sometimes repeated surgery may not be the best option. So how do we treat a patient with a nerve damage problem? So using what we call spinal cord stimulator, it's using what we call a pacemaker for pain. They're like small little catheters, just like a regular pacemakers that you see that people with heart problem have. We can put into the epidural space, kind of like to descramble the pain signal. So you do like a trial, a test drive first, putting the catheter into the epidural space. If the patient does well with it, then we can actually implant the pacemaker just like you would do, like the pacemaker for pain, just like you would do for like a cardiac problem. So these conditions are complex. So that's why we spend a lot of time with patients explaining to them exactly what the problem entails and what the treatment algorithm is going to be, and offer the patient a lot of the options that are available to them.
And this does take a long period of time, doesn't it, before we get to a failed back syndrome and then the implementation of a spinal cord stimulator?
Absolutely. So it's like sometimes we see patients that have problems for like a year or two before we make that decision. And the thing is, like, if it's the right decision to make, and we always have the conversation with the patient to make sure that's the best option for them.
And now that spinal cord stimulator, not the trial, but the final, is that a permanent implant?
Yeah, it's a permanent implant, just like a pacemaker. I'm not sure if you ever see a patient that has what we call a pacemaker for their heart. Sometimes they'll have like a small little device that gets put in the chest. So we do the same thing. We put it in the back, but specifically targeted for the nerves of the back. So once you put it, it's a permanent implant where the patient's going to keep this for the rest of their lives to be able to help reduce the nerve by sending electrical pulses directly to the nerve itself.
Oh. Going to permanency, a lot of times in the personal injury realm, there's a different definition of permanency in the legal community, and there's a definition for permanency in the medical community. Can you address that?
Yes, so in the legal community, and also the same thing occurs in the medical community as well. So a condition becomes a permanent condition, like a disc herniation, because no matter how many surgical procedures, injections that you're going to do, the disc will never function the same way that it's going to do normally. So once you have an injury to a disc, even you can fix it by doing a discectomy to reduce the patient's symptoms, but the patient's going to lose some function of that disc. Instead of working 100%, it's going to work at 75%, at 50%. The patient may have less pain, less discomfort from time to time, but the patient always have some kind of limitation in their functional ability. So the legal terms, it's what that permanency involved, but on medical terms, it's the same thing, just because the medicine dictates what happens to the patient. And no matter what fusions. I mean, we have a lot of great surgeons in our community that do a very good job with our patients. However, the patients may become a little bit more comfortable, be able to enjoy life a little bit more, but they will never be 100% the same. They're going to have some limitation in the work that they can do, the type of activities that they can engage with. So that's what makes it a permanent condition.
How do you decide as a physician what treatment is appropriate as opposed to what would be inadequate? And how can you ensure that your patients are receiving the best possible care for their injuries, especially in the light of the fact when you may be battling with an insurance company?
Yes, so that's one of the biggest challenge in medicine is the insurance companies, because a lot of times the way that we want to treat a patient, sometimes the insurance may, it's not to say that they're not agreeing, but it's like it makes you jump through hoops. So meaning that if a patient has a disc herniation compressing the nerve, the patient has back pain going down the legs, and you can actually see the MRI, you see objective evidence clearly and visually, but you try to pre-cert an epidural steroid injection, meaning that asking the insurance permission to get the injection done. Sometimes the insurance refuses for one reason or another. Sometimes it's, I cannot understand why, because they approve the MRI, we see the pathology, we're asking, can we do something about it? And they say no. And so that's what makes it somewhat a little bit challenging to be able to do that. So the appropriate thing to do is a lot of time what I do is like I get on the phone with the insurance company to try to talk to like somebody, a supervisor, to explain the pathology, that I have a relationship with the patient. The patient has a back pain. This is what the MRI shows. So it's doing a lot of work for the patients, putting your best foot forward to be a patient advocate, to make sure that they can actually get the therapies that you are indicating for them.
And a lot of times, if you receive a denial from the insurance company when it's related to an automobile collision, there's a process called an arbitration.
Correct.
And how long does that process take? And what do you do if you have an injured patient and they desperately need the treatment, but you received the denial from the insurance company to go ahead with the procedure?
Yeah, so typically, I mean, right now they have what they call, there is a step process. So if you're requesting a procedure, the patient, the insurance denies it, you have the right to appeal the procedure and then resubmit again. If they deny it again a second time, and we as a medical professional that's seeing the patient, we feel it's necessary, we can go along and do the procedure just to provide the care for the patient. But the caveat to that is we have to wait until we can get compensated for the procedure through an arbitration process. So meaning that it can take 6 months, can take 2 years, can take a long time before you get paid. But we as patient advocate, we always want to make sure that regardless, if we feel that the patient actually needs it, because we see the patient on a regular basis. The insurance company does not see the patient. Even when the patient gets what they call an IME, which is an independent medical exam, a lot of times the patient goes there to that doctor, the insurance doctor, for like 10 minutes, and the IME doctor said, you don't need this. But a lot of time I have great relationship with the patient for 3 to 6 months. We see the patient on a regular basis. So if we feel as a board certified doctor that the patient needs the procedure, so it's my job to make sure that I go to bat for the patient, to make sure I do everything that I can to offer the patient the therapy that's needed, so that we can actually, the patient can have less discomfort and move on with their lives.
Another favorite argument of the defense, as you're well aware, is that the injuries are not caused by the trauma related to the collision or the fall, whatever the case may be. And they're arguing that it's degenerative. How can you differentiate a degenerative condition from an acute condition caused by trauma?
So a lot of times, so degeneration, actually, it's a medical term that indicates what we call age-related process, meaning that if you're looking at the lumbar disc, like I mentioned to you before, over time, you're going to start losing fluid. So the radiologist, the term that we use in a medical term, we call it degeneration, meaning that because the disc starts to lose the water content. But it doesn't mean that it's an old problem per se. So a lot of time when you're looking at the film, the MRI, typically there's a lot of things that you can look at, looking at the size of the height of the disc. So if the disc has a nice height, and you know that it's not a degenerative disc, it's actually a disc that's age appropriate. So in terms of like an age of determining is it secondary to the accident or not. So a lot of time the things that we use is if the patient had any previous problems before, you would probably know, because a lot of time when you do a physical examination, loss of reflex, like losing like a muscle spasm, these are not something that's going to occur where the patient had it for a long period of time where they never did anything about it. So we use not only the film as part of the puzzle, but we also use the history and the physical examination to put everything together.
You mentioned what you'll do if your treatment is denied. What if a person doesn't have insurance and they're involved in a traumatic event? What are their options then?
So if the patient doesn't have any insurance and they're involved in a traumatic event, so typically what I'll do is I'll have conversation with the patient, and sometimes if the patient has any legal representative, somebody with the office will make sure to contact that legal representative if they do to what they call to protect any of the procedures that we do, because I would love to do work for free. However, the procedures get done at a surgical center. So the surgical center often are not our center. We take them to a hospital like St. Peter's, Robert Wood, and any of the hospitals around. So there's a cost associated with it. So that means that we want to make sure that we provide the patient the care that they need. But at the same time, if they have no funds, we can still move forward as long as my office have a discussion with the legal representative to make sure that we can actually work out an agreement where we make sure that we offer the patient the care that is necessary, and everything takes care on the back end.
And then that attorney could issue what's called a letter of protection, which means they're going to protect your bill out of a future settlement.
Exactly. That's exactly the term, letter of protection.
And if the case by some chance is lost, what happens to that letter of protection and what happens to you?
So essentially, so in our case, in our practice, so again, we're patient advocate first. I mean, again, that's part of the reason we're into medical schools to help patients. So even though we get what we call letter of protection to help to protect the bill, I mean, to protect our fees, but if the case is lost and the patient does not have any money, so a lot of times we chuck it to community service, you know what I mean? Because at the end of the day, I'm not gonna go after a patient like that is injured and I offered my services, the patient doesn't have any money. So I don't go after the patient for that. So a lot of time it's actually the patient, as long as the patient's satisfied with my care, the patient's doing better, able to go back to work, able to take care of their families in terms of like being around. So sometimes it's actually good enough for me. You know, I mean, again, we hope a lot of time that doesn't happen a lot, but in case that it happens, completely fine. I mean, we have good relationship with our patients to make sure that that's one thing I always tell them. We're not gonna beat them up if they cannot pay a certain bill. We're not gonna go and hold them accountable or anything like that. So all good.
So along those lines, any recommendations to somebody suffering a traumatic injury as to how to choose their medical providers and how to choose a good lawyer?
So the best thing with a medical provider, it's making sure that, for example, myself, interventional pain physician, making sure that one, the person has done an appropriate fellowship. So I'm fellowship trained, meaning that after completing my residency, I spent over a year and a half being a specialist in pain management, doing a formal, what we call a fellowship program when I'm actually becoming a specialist. Not only that, I'm board certified in the field of study in both of my specialties. I'm board certified, and make sure the doctor has a lot of good reviews, a lot of experience. I've been doing this for 18 years now by myself. I mean, meaning that in my own practice, I mean, I've been practicing for 20 years. So I have a lot of experience, board certified. I did a fellowship. I have good reviews. And again, like you mentioned earlier, if you travel some magazine, you're going to see me there just because a lot of my peers have voted me top doctor in New Jersey and New York. So I get a lot of accolade because I do good work. So that's one of the things in choosing a doctor. In terms of a good attorney, in a similar way as well, making sure that the lawyer himself is sometimes if a lawyer is like a trial lawyer, meaning that the person has experience to take your case to court, meaning that a lot of times if you get an injury, sometimes the insurance company may not want to settle right away. So the attorney has to say, okay, I want to take this case to court. So that means that you have to have an attorney that's certified by a trial lawyers association, that you can actually take your case to a trial to make sure that you're properly compensated for your injuries. And also looking at reviews where the attorney went to school. So a lot of it in experience as well. So all these factors is very important in choosing both your legal representation and your healthcare provider.
Thank you, Dr. Demesmin. Ladies and gentlemen, Dr. Didier Demesmin, one of the top interventional pain management doctors in the world.
I appreciate it. Thank you so much, Mr. LeBrocq.
Thank you. Where are you watching?
Thank you for tuning in to Victim to Victory, the Personal Injury Playbook. We hope you found today's discussion insightful and helpful as you navigate the complex legal system. If you or someone you know suffered from a personal injury, don't hesitate to reach out to us at 1-800-489-0004. Our team is here to help take you from victim to victory. Remember, taking legal action after a personal injury is a critical step in protecting your rights and securing your future. So don't wait. Make the call today and let us help you fight for the compensation you deserve. We'll be back next week with more expert insights and information.
This podcast is intended for informational and educational purposes only and should not be considered legal advice. The content of this podcast is based on the laws and regulations of the United States and may not be applicable in other jurisdictions. Additionally, any information shared on this podcast is not protected by attorney-client privilege or any other type of confidentiality. Remember, this podcast is for informational and educational purposes only and should not be considered legal advice.